You know, usually when we talk about treating a medical condition, there is this like baseline expectation of physical repair.
Right, like you break a bone, the doctor sets it, and your body just inherently knows how to build new bone to, fuse the gap.
Exactly. Or you get a cut, you get some stitches, and your body builds new skin. It's a very satisfying, highly visible process.
Yeah, we really take that biological architecture for granted, I think. We just expect our local tissue to simply know how to rebuild its own scaffolding the second the immediate crisis is handled.
But then you step into the world of chronic inflammatory dermatosis,
Mm.
right? And mucosal degradation. Specifically, things like vulvar lichen sclerosis or VLS and menopause-induced vaginal atrophy.
Which is a completely different reality.
Totally. Suddenly, that internal construction crew hasn't just walked off the job,
Mm.
but like the body is actively dismantling its own foundation.
Yeah, it's this profound failure of the local microenvironment. The blueprints for a repair are sitting right there on the table, but the cellular communication lines are just completely severed.
Which is exactly what we're getting into today. Welcome to the Deep Dive. I'm your host, and today we're taking you into this cutting-edge intersection of women's health, autoimmune dermatology, and really regenerative medicine.
And as an immunological researcher, I'm thrilled to be here to break this down with you. We have a fascinating stack of medical literature to go through today.
Yeah, we are pulling from a 2023 prospective study on dermoscopy, some really detailed case reports on plant-derived and stem cell-derived therapies, and some current clinical FAQs on regenerative practices.
The mission for this deep dive is to really look at how novel therapies, specifically exosomes and stem cells, are being deployed against these chronic tissue-altering conditions.
Because, I mean, for decades, the pathology of VLS and atrophy was treated as this one-way street, right? Clinical success was defined purely by how slowly the tissue degraded.
Exactly, just slowing down the inevitable.
Okay, so let's unpack this.
Yeah.
Historically, standard care for VLS and vaginal atrophy has been heavily focused on symptom management. Suppress the immune response, stop the itching, stop the pain.
Right, put out the immediate fire.
But the literature we are looking at today is asking a fundamentally different question, which is, can we actually reverse the structural damage? Like, can we force the tissue to rebuild its own foundation?
But before we can get into those regenerative solutions, you really need to understand the cellular hostility of these conditions.
Yeah, what is actually happening in the microenvironment that makes VLS so notoriously difficult to treat?
Well, let's look at the pathology of VLS. It's an immune-mediated disease characterized by a really aggressive Th1 cell response.
So the immune system is just constantly deploying its heavy infantry to the local tissue.
Exactly. And driving this relentless assault are highly elevated levels of microRNA 155, or you'll see it called miR 155.
Right, and we see miR 155 popped up in a lot of autoimmune literature as this, like, master regulator of inflammation.
Absolutely.
But I want to make sure we understand the mechanism here. It's not just a passive marker, right? I mean, miR 155 is actively intercepting the tissue's normal, like, tolerogenic signals.
That is the exact mechanism of action, yeah. It's basically rewriting the local communication so that the Th1 cells are tricked into viewing healthy native tissue as a foreign threat.
Wow.
The miR 155 upregulates the inflammatory cascades, but simultaneously it silences the pathways that would normally tell the immune system to stand down.
And what are they attacking exactly?
Well, the primary target of this localized attack is extracellular matrix protein 1, or ECM1.
And that's a big deal.
A huge deal. This autoantibody response against ECM1 is devastating because that protein isn't just like structural filler. It is the core scaffolding of the dermal structure.
Right, it holds everything up.
And it's absolutely vital for the maintenance of local blood vessels, too.
So the immune system is literally dissolving the tissue's structural integrity and its blood supply at the exact same time.
Yes, and the downstream effect of this constant immunological warfare is a highly oxidative environment.
Which we saw in the literature as massive lipid and DNA peroxidation.
Exactly. The tissue is essentially rusting from the inside out, and that is what drives the severe architectural distortion and progressive fibrosis, or scarring.
God, that sounds awful.
Yeah.
And then, while the trigger is entirely different, the structural endpoint is strikingly similar in menopause-induced vaginal atrophy, right?
Yeah, the end result looks very similar. In atrophy, the systemic withdrawal of estrogen simply starves the tissue of its maintenance signals.
So the mucosa thins out, the vascular networks collapse, and the tissue just loses all its elasticity.
Right. Both conditions culminate in this degraded, incredibly hostile microenvironment where healthy fibroblasts just cannot survive, let alone replicate.
Which brings us to the frustration with the traditional standard of care. I mean, usually patients are prescribed high-potency topical corticosteroids or calcineurin inhibitors.
Right, the standard first-line defense.
But if we go back to our building metaphor, applying these steroids is kind of like using a heavy-duty fire extinguisher.
That's a perfect way to look at it.
Right. It puts out the active flames, it shuts down that Th1 response and the miR-155 signaling, but it leaves you with a burned-down house. You just have this charred, fibrotic scaffolding left over.
Yeah, the fire's out, but the damage is done.
So I have to ask, if the immune system was actively attacking ECM1, why don't traditional pharmacological treatments just rebuild the ECM1?
Well, what's fascinating here is that corticosteroids are fundamentally suppressive. They're not constructive.
Okay.
A steroid molecule forces the immune system into submission, right? But it does not contain the biological instructions needed to synthesize new collagen or upregulate elastin or stimulate angiogenesis.
It just doesn't have the code.
Right. It can't dictate cellular remodeling at all. It can only enforce a ceasefire.
Man, so it's essentially slapping a bandage over a deteriorating foundation. The inflammation might be paused, but the tissue remains thin, scarred, and highly fragile. And this perfectly frames the pivot in our sources toward regenerative medicine. Because if the traditional drugs don't carry the biochemical blueprints to rebuild, we have to find a biological vehicle that actually does.
Which brings us to the focal point of our dive today. Exosomes.
Yes, exosome.
Exosomes are forcing a massive paradigm shift in how we approach cellular repair right now. But to grasp what they're doing, you have to separate them from the concept of live stem cell therapy.
Right, because they aren't cells.
Exactly. Exosomes are cell-free extracellular vesicles. We are talking about lipid-bound nanoparticles, typically ranging from like 50 to 100 nanometers in size.
They're unfathomably small. I mean, you could fit millions of them on the head of a pin.
Easily. And they're naturally secreted by cells purely for intercellular communication.
And looking at the case reports, these vesicles are being harvested from all sorts of places. Human umbilical cord, mesenchymal stem cells, adipose or fat tissue, and remarkably, even from plants.
Yeah, like Rosa damascena, the damask rose.
Which is wild to me. But here's where I get tripped up. If they are cell-free-like, if they don't have a nucleus and they aren't actually alive, how do they execute any repairs in the tissue?
That is the million-dollar question.
Right. Like, what is doing the heavy lifting if it isn't a live cell?
The heavy lifting is done entirely by the cargo they carry. These vesicles are just packed with a highly concentrated, biologically active payload.
Okay, what's in the payload?
They contain VEGF to initiate angiogenesis new blood vessels alongside growth factors like BFGF and PDGF. And crucially, they carry messenger RNA, microRNAs that actively counteract that inflammatory miR-155 we talked about, and heat shock proteins.
Specifically HSP70 and HSP90, right?
Yes. And those heat shock proteins act as an immediate biological shield. They wrap around the recipient cells to protect them from that intense oxidative stress and lipid peroxidation we were seeing in VLS.
Okay, I like to think of exosomes as a cellular software update.
Oh, I like that analogy.
Yeah, like they aren't the live stem cells, which would be the hardware. They are more like zipped folders of biochemical code.
Exactly.
When they breach the tissue, they fuse with your existing dormant fibroblasts, unzip, and deliver this payload of mRNA and growth factors. They essentially tell your own cells to wake up, update their software, and start remodeling the damage.
That's a perfect way to visualize it. And because it's just the software, not the hardware, you completely bypass the biggest hurdle of traditional stem cell therapy.
Which is the immune system.
Right. That lack of cellular hardware is the defining advantage of exosome therapy. Because they are cell-free, they do not express MHC class I and class II proteins on their surface.
And those are the specific molecular identifiers our immune system uses to flag foreign cells.
Right. Exactly. Without those flags, the risk of host immune rejection or a graft versus host reaction drops to near zero.
Meaning you eliminate the fear of transferring donor DNA or forming tumors like teratomas, which has always been this dark cloud hanging over live stem cell applications.
The safety profile is completely altered. The entire mechanism relies on paracrine signaling.
Which just means local cell-to-cell communication.
Right. The exosomes arrive, dump their cargo, and stimulate the patient's endogenous systems. For instance, the literature shows they aggressively stimulate endogenous hyaluronic acid synthase, or HS2.
Which naturally hydrates and plumps the tissue.
Yes, and they physically regulate the collagen to elastin ratio. They are commanding the native tissue to remodel itself without introducing a single foreign live cell that could mutate or go rogue.
That cross-kingdom communication is just wild to me. The idea that a plant exosome from a damask rose has a lipid bilayer conserved enough through evolution that it can successfully fuse with a human perimenopausal cell and transfer RNA to stimulate HS2.
It really does sound like science fiction.
It does. But, a biological mechanism is only as good as its clinical outcomes. Does this software update actually execute when you take it out of the petri dish?
It does. The clinical evidence from the recent case reports and animal models is highly compelling.
Let's talk about those models.
So the foundational animal models used ovareectomized rats, which is the standard proxy for mimicking the systemic estrogen crash of menopause. Researchers loaded umbilical cord stem cell exosomes into a hydrogel for vaginal delivery.
And they didn't just measure like a reduction in dryness or subjective symptoms, right? They were looking at hard cellular markers.
Oh, yeah. They saw a profound structural reversal. The exosome-treated tissue showed massive upregulation of Ki67, which is the primary marker for active cellular proliferation.
Okay.
And that was alongside soaring CD31 expression, which indicates robust angiogenesis. The researchers physically measured a thickening of the vaginal epithelium. The mucosa wasn't just surviving, it was actually proliferating.
And we're seeing this translate directly into human applications, too. We have a documented case study of a 41-year-old perimenopausal woman suffering from severe recurrent atrophic vaginitis that was completely refractory to standard hormone treatments.
Right, nothing was working for her.
Nothing. And she received 3 billion Rosa damascena plant exosomes, reconstituted with hyaluronic acid, applied over 3 sessions.
The results of that were incredible.
Yeah, the post-treatment biopsies revealed her epithelial thickness had increased by roughly 2.5 millimeters. Her tissue structurally rebuilt itself, and the clinical symptoms just vanished.
That 2.5 millimeter increase is literally the biological architecture returning online.
It's amazing.
But it isn't limited to the estrogen-starved environment of atrophy. There is also a compelling case report of a 39-year-old male with a 15-year history of refractory genital lichen planus, which is pathophysiologically adjacent to lichen sclerosis.
Oh, wow. 15 years.
Yeah, and after a daily home application of exosomes combined with in-office microneedling, paired biopsies showed qualitative attenuation of the interface dermatitis.
So the immune infantry was finally retreating.
Exactly.
And looking specifically at VLS, there was a study involving 22 lichen sclerosis patients treated with adipose tissue stem cells that demonstrated a significant reduction in sclerosis and tangible tissue remodeling.
Yeah, the clinical results are really speaking for themselves.
Now, here's where we need to look at the delivery mechanisms, because we are seeing tissue regeneration across entirely different sources: plant-derived rose exosomes, adipose-derived, umbilical cord.
Right. The tissue origin obviously dictates the specific profile of the growth factors inside the vesicle.
But the delivery seems to be the real bottleneck, doesn't it? I mean, if these nanoparticles just sit on top of heavily fibrotic hyperkeratotic skin, they can't deliver the software update, right?
Delivery is absolutely the primary hurdle. Exosomes must breach the mucosal or epidermal barrier to interact with the target fibroblasts.
Makes sense.
If you apply them topically to a heavily scarred VLS plaque without a permeation strategy, the vesicles just degrade in the hostile extracellular environment before ever reaching the lamina propria.
Which totally explains why the clinical protocols in these reports universally pair the exosome application with physical delivery mechanisms, like microneedling, fractional CO2 lasers, or electroporation.
Yes, they are physically punching microchannels through the fibrosis
to ensure the exosomes bypass the hostile surface and deploy their cargo directly into the deeper dermal layers where the actual remodeling happens.
Exactly. And that brings us to how we actually quantify this remodeling in human patients. Historically, clinical success in these dermatoses relied heavily on subjective patient reporting.
Right, like did the itching stop? Did the pain decrease?
But subjective symptom relief doesn't actually prove the scaffolding has been rebuilt.
No, it doesn't.
Today, the standard for evidence is shifting toward advanced, non-invasive imaging. The 2023 prospective study we reviewed highlights the deployment of dermoscopy and reflectance confocal microscopy, or RCM.
Let's talk about RCM because it effectively functions as an optical biopsy.
It really does.
Instead of just taking a doctor's visual assessment of the tissue, RCM allows clinicians to look beneath the surface in real time. They aren't just tracking the reduction of the white structureless areas under dermoscopy.
Yeah.
With RCM, they are literally counting the density of inflammatory cells.
And physically measuring epidermal thickness down to the micrometer over the course of the treatment.
They are objectively quantifying the regeneration, cell by cell, without having to repeatedly excise tissue from an already traumatized area.
Which is a huge relief for the patients.
That level of microscopic tracking is incredible,
Yeah.
but it leads us directly into, honestly, the most controversial part of our stack today. Because for all the objective tracking RCM provides, there is a massive clinical gray area in how these therapies are actually being administered.
Yeah, we have to talk about the reality of clinical application.
I want to look at a highly specific, very complex clinical scenario from our sources. What exactly is the protocol for adjusting exosome dosage in patients presenting with combined severe atrophy and active lichen sclerosis?
That is the defining question in regenerative gynecology right now. And the hard truth, which is explicitly detailed in a recent pilot study on laser-assisted exosome delivery, or LEED, is that there are currently no standardized protocols.
None.
None. We are operating in the wild west of regenerative dosing.
See, I want to push on this because this is exactly where patients get taken advantage of. If a patient with severe atrophy and active VLS walks into a boutique clinic, and that clinic hands them a glossy brochure with a guaranteed proprietary protocol detailing the exact exosome concentration and frequency for their dual diagnosis,
Right.
the literature we are reading says that clinic is basically making it up. How do they know if a dual diagnosis requires doubling the dose or spacing the treatments differently if global standards don't exist yet?
You are absolutely right to challenge that. The scientific reality is that these clinical FAQs and boutique protocols are based purely on localized experiential data. They are not rigorous, multi-center, double-blind, FDA-approved trials.
So what are clinics actually doing?
Well, current experiential guidelines might suggest applying between 2 to 5 billion extracellular vesicles per session, spaced 4 to 6 grain apart, utilizing a fractional CO2 laser for delivery.
But that 2 to 5 billion number is just an educated guess based on early observation. It is not subtle pharmacokinetics. If a clinic is promising a guaranteed hyperspecific titration for complex overlapping conditions like atrophy and VLS, they are front-running the science.
They are. The field is rapidly accumulating data, yes, but we do not yet have the codified algorithms for how to adjust exosome payloads when you are fighting both estrogen withdrawal and an active autoimmune Th1 response simultaneously.
And this lack of standardization dovetails directly into the safety profile. We established earlier that exosomes are cell-free, so they won't form teratomas or trigger graft versus host disease.
Right, they are safe from that perspective.
But they possess one biological superpower that acts as a massive double-edged sword: angiogenesis.
Yes. Angiogenesis is the holy grail for atrophied fibrotic tissue. You desperately need to synthesize new vascular networks to bring oxygen and nutrients back to those suffocating fibroblasts.
And VEGF, vascular endothelial growth factor, is one of the most potent components of the exosome cargo.
But there is one microenvironment where you absolutely never want to deploy highly concentrated VEGF to build a new vascular network.
Inside an undetected tumor.
Precisely. This is the critical safety bottleneck. Because exosomes so efficiently promote angiogenesis and cellular proliferation, they must never be introduced near active pelvic malignancies or undetected precancerous lesions.
Conditions like VIN, or CIN vulvar, or cervical intraepithelial neoplasia?
Exactly. Those can be clinically silent. If a practitioner blindly introduces 5 billion exosomes into a tissue bed harboring a hidden malignancy, they aren't just failing to treat the atrophy.
They could theoretically construct a vascular highway that actively feeds the tumor.
Yes, it could rapidly accelerate the growth.
Which means that careful, rigorous patient screening by a qualified physician is absolutely non-negotiable.
100%.
You cannot bypass standard oncological surveillance, the biopsies, the pap smears, the cancer screenings, just because a clinic markets a therapy as a natural or cell-free regenerative cosmetic procedure.
The biological pathways that heal healthy tissue are the exact same pathways that a malignancy will hijack to grow.
Wow. Okay, so the potency of the therapy demands an equally potent commitment to clinical surveillance. You have to verify the cellular landscape is clear of dysplasia before you authorize a localized software update that triggers massive proliferation.
Perfectly said.
Okay, let's pull all of this together for everyone listening. We started by dissecting the hostile microenvironments of lichen sclerosis and menopause-induced atrophy.
Right, these are landscapes where MUR155 tricks the immune system into dissolving its own scaffolding, or where the systemic loss of estrogen starves the tissue into a fragile fibrotic state.
And we saw how traditional standards of care rely on pharmacological fire extinguishers that, halt the inflammation but lack the biological blueprints to rebuild the house.
Then we examined the regenerative pivot to exosomes. These 50-nanometer cell-free vesicles bypass the immune system entirely, delivering a potent payload of mRNA, growth factors, and heat shock proteins directly to the dormant fibroblasts.
And we saw the clinical translation of that payload. Case studies showing physical thickening of the epithelium and the attenuation of chronic interface dermatitis, all quantifiable in real time through reflectance confocal microscopy.
But we also confronted the reality of the Wild West. We do not have standardized dosing protocols for complex dual diagnoses of atrophy and VLS.
And the incredible angiogenic power of exosomes requires absolute vigilance to ensure we aren't accidentally feeding hidden malignancies.
It is a profound shift in medical capability, but it has to be balanced against the urgent need for standardized clinical guardrails.
And for you listening, even if you aren't personally navigating a diagnosis of VLS or vaginal atrophy, the underlying principle we explored today is just breathtaking. We're watching the leading edge of medicine move away from drugs designed merely to suppress our biology and towards cell-free therapies that utilize our body's own agent communication networks to reverse chronic degradation.
It fundamentally rewrites our understanding of what constitutes permanent structural damage.
It proves the blueprints for repair are always there. They just need the right molecular signal to execute.
Absolutely.
Exactly. Which brings me to a final thought for you to explore on your own. We talked a lot about the massive oxidative stress and DNA peroxidation present in the VLS microenvironment.
Yeah, all that rusting from the inside out.
Right. And we know that chronic long-term DNA damage in these highly inflamed tissues is exactly what drives the eventual development of squamous cell carcinoma in a specific subset of patients. So exosome therapy floods the tissue with heat shock proteins that specifically shield cells from that exact oxidative stress, and if it successfully remodels the hostile microenvironment, could early targeted intervention with exosomes actually prevent the transformation of chronic inflammatory conditions into localized cancers?
That is a fascinating question.
Are we not just repairing the scaffolding, but actively stopping the oncological clock before the first malignant mutation even occurs? Think about that the next time you hear that a degenerative condition is irreversible. The foundation might be severely damaged, but it turns out the cells were just waiting for a software update.